So welcome to the Fujifilm Healthcare webinar organized in occasion of the ISUOG Congress. Thank you very much for joining. This is one of our educational activities that we are arranging for this Congress. My name is Luca Mastrogirolamo. I am European Clinical Support Manager for Fujifilm Healthcare in Europe, and I will be your facilitator for this event. Today, we are very pleased to have as a panelist of this webinar, Dr. Gilles Grangé and Dr. Penelope Noble from Maternité Department of Port-Royal site of Cochin Hospital in Paris, France. Dr. Gilles Grangé and Dr. Noble are both obstetrics and gynecology doctors. They are experts on ultrasound in fetal medicine. They have a very long expertise in ultrasound scanning, and they're also involved in the French diploma for the accreditation. So we are very happy to have them today. Today they will present us a lecture with the title Placenta, accreta and percreta, How to Diagnose. You can place also your question on to Dr. Grangé, Dr. Noble on the chat of this platform. So we will be happy to submit them to our panelists. So I'm really pleased to introduce Dr. Gilles Grangé and Dr. Noble. Thank you very much for joining us. And I think we can start. The floor is yours. Thank you.
Okay, thank you very much, Luca. Thank you. Let's go. So we need tools to describe placenta. So let's see them together. Just things that are reassuring and those which are more concerning.
So why is it so important to diagnose placenta percreta and accreta antenatally? Well, we can see here from this study that abnormally invasive placentas are associated with a high degree of maternal morbidity and even mortality. Severe maternal morbidity is 3 times more frequent in patients with percreta than accreta. Percreta, of course, is when the placenta invades through the myometrium, through the uterine serosa, and can go through to adjacent organs, most notably the maternal bladder. So at the time of delivery, this can be quite complicated. It can be difficult to gain access to the baby, and the mother may suffer from severe hemorrhage at the time of delivery. And this can be seen here in this table on the right-hand side, particularly in pregnancies complicated by percreta. This can result in transfusion and admission to the intensive care unit. Also, at the time of delivery, it has to be decided on whether to surgically remove the placenta and the part of the uterus that is affected, or even do a hysterectomy at the time. And this adds further complications, and we can see at the bottom of the table, there's a certain degree of bladder injury that can be sustained in these cases, particularly, again, in pregnancies associated with percreta. In cases where conservative management is considered, there's also a high risk of delayed hysterectomy. So essentially, these are complicated pregnancies that need very specialized care.
Okay, so diagnosis of accreta and percreta is via ultrasound. It is subjective and therefore dependent on the skill of the operator. And let's see that we have some FIGO, an European Working Group on Abnormal Invasive Placenta, who have suggested standardized definitions. They defined some ultrasound markers in order to facilitate clinical description and future research into the diagnosis and treatment. So let's see all of them. Those one are the one of FIGO, and we can see now with our team what's going on. So those are our signs.
So the European Working Group for Abnormally Invasive Placenta came up with 3 groups of ultrasound signs. to look for. The first group is ultrasound signs seen on 2D grayscale ultrasound. The second group is 2D color Doppler. And the third group is seen in 3-dimensional ultrasound. So we'll be looking at the first two groups, and starting with 2D grayscale ultrasound, we need to look particularly at the location of the placenta. Is the placenta anterior or posterior? Is it covering the internal cervical os, like a placenta previa? And we need to look at the plane between the placenta and the myometrium, this clear zone, this hyperechoic plane. So Gilles Grangé will show us videos and describe on the videos the various ultrasound signs.
Okay, we show you a very pragmatic way to describe signs about accreta and percreta. So let's see the first video. Okay. Video shows the importance of doing the scan with a full bladder. Mother will need to drink quite a bit, and it's a little bit long to get this bladder, and it's very uncomfortable and a little bit painful. So you have to be patient and to explain the mother that it's a little bit painful. This way, it allows a good view of the placenta. Here we can see it, of the myometrium and the bladder, the wall bladder wall. So in this video, we can see that the placenta is anterior and extending to the internal cervical os, which is just right here. You see the cervix here, okay. And there is an hypoechoic which is the clear zone, this hypoechoic area, which is a clear zone between the placenta and the bladder wall. And this is a very important part of this area because it's reassuring. We are not so worried about this placenta because we can see the clear zone right here. Okay, let's see another example. Okay, this one is very different. You can see a placenta there, which is anterior. The internal os is in this area. It's a little bit far away, but you can see the bladder wall and the placenta, and there is no clear zone between placenta and this hyperechoic line. So it is more concerning. Okay, next sign. Okay.
So looking in more detail at the placenta, we need to look at the number of placental lacunae, which are irregular hyperechoic areas, which can present with a halo, a hyperechogenic halo surrounding them, or without halo.
Okay, let's see that. Maybe it's a little bit difficult to see the difference between those two. Okay, this is the third one, which is a big lacuna, which is from the basal, the base plate, from the base plate to oops, whoops. Can we go back? Yes. No. Can we go back to the last? Oops. Yes, that's it. Okay, so this lacuna is not so worrying because we have a swirling inside, and it goes from the base plate to the surface of the placenta. So it's not so worrying. It is not a lacuna which is related to accreta or percreta. Now let's see another placenta. There. Okay, this is lacuna that we have to look after. This one has an hyperechoic halo. This one also. So it's a little bit worrying, but not so much as another one, like this one, where you don't see any hyperechoic halo around, or maybe you can see just a second, this one. You see there's no, this one, maybe you saw it. There's no hyperechoic halo surrounding this lacunae. So this one is very more concerning. Okay, let's see this one. Maybe this one has a little hyperechoic halo around it. This one, no hyperechoic halo. This one is very worrying, lacunae. And what about this one? This one is not so reassuring. Let's say that the skill of the operator is very important, and the settings are also important. The setting of the ultrasound machine, they are you can transform the aspect of the lacuna depending of the settings. Okay.
So now we need to really turn our attention to the maternal bladder and look for the bladder wall and see if there's any interruption or discontinuity with the hyperechoic line that we see between the bladder and the uterus. And remembering that we have a full maternal bladder for this ultrasound examination, so we can see if there's a placental bulge of the uterine serosa in towards the maternal bladder. And we need to look to see if we can see any evidence of placental invasion into the bladder, which is particularly, along with placental bulge, is particularly indicative of placenta percreta.
Yeah, that's the signs of percreta. So let's see, this is the bulge into the bladder. You see this this bulge into the bladder, okay? And it's associated with the lacunae there with no hyperechoic surrounding, and no more clear zone between the placenta and the bladder wall. So this one is more concerning, very worrying. Okay, let's see another video. Okay, this one. Once again, we don't see any clear zone between the placenta and the bladder wall, and there's no bulge of the placenta into the bladder, but we have an interruption of the bladder wall. You can see this hyperechoic line, maybe in this area, and after it stopped again. This is very worrying. This one was percreta, placenta percreta. You can see some exophytic aspect here. You see, so it's not. It's very worrying. Placenta.
Okay, so those are the suggested ultrasound signs indicated by the European Working Group. But two additional signs which are worth looking for are calcification seen in the base plate or calcification seen in the suspected area that you're interested in.
Yes, it's very specific from our team. So we are looking at the calcification on the base plate right here, you see. And when it is present, it's a good prognosis. I've never seen any percreta or accreta with this sign. So we're looking at it, and if it's present, we're reassuring. But it's not described in the literature, so it's very personal sign.
Okay, so moving on to the second group of ultrasound signs that we see, and for these we need to be using the colour Doppler. And so we start with looking at hypervascularity in the subplacental region and also in the uretovesical region.
Okay, so this is an interesting way to analyze the placenta. So let's see, we have to analyze these the vessels between the placenta and the bladder wall and in the myometrium. So in this area, and one thing which is important is to see the settings about PRF, you know, and you can look at the speed scale. And you can see here that the speed are very low. So those vessels are not so worrying because those vessels have a speed which is very low. Let's see another example. So this placenta, you can see this placenta, which is anterior on the internal os, and this one was worried for the other teams, and we said that it was not so concerning because it is the speed were low. Let's see another example. Okay,
yes,
slide after
so,
this one. Okay.
So basically, as well as just the hypervascularity in the subplacental area, we need to be looking at the bridging vessels as well. So these are vessels that run perpendicular to the base plate and the adjacent organs. And again, we're looking at the velocity of flow within not just the direction of the vessels, but also the velocity of flow within these vessels to get an idea of how concerning this is.
Okay, let's see on the color Doppler. So we have some perpendicular vessel here and here, but you can see once again that the speed scale is very low. So this is it is not so concerning. Okay, but there is a very rich vessel area here, but once again, speed are slow. Okay, let's see another one. Okay, this one, look at this one. The PRF is not the same. On the scale, the speed are to 70 centimeters per second, and the vessels are still seen. So the speed are very high, and this placenta is more concerning, of course. And you can see the difference. There is a little bulge there, and lacunae, and so on. What we have already seen. No clear zone, but you can see that maybe you can say that it's a clear zone, but it is not, because those images are vessels, but they are not myometrium. So this placenta is concerning. Okay, once again, you have a lot of vessels there. The speed is very high. The vessels are still seen, and with a very high speed on the color Doppler. And there's no clear zone, and you can see that the bladder wall is interrupted on some places. And there is a new sign here, which is a railroad vessels. You see the vessels are just like are parallel. And so it's like a railroad vessels. And you have perpendicular vessels in lacunae. So it is very worrying.
So also we need to look at the color Doppler in the placental lacunae, and again the feeder vessels that come through, and again we're looking at the velocity of the flow as well in the placental lacunae.
Yeah, so let's put a gate in this image, and you can see the speed of the blood inside the lacunae. So in this example, you can see that it's only 10 centimeters per second, so it's not so high. Okay, let's do another one. Okay, in this one, it's maybe about 75 centimeters per second in this placenta. So this one is more worrying. So this one was percreta. So it was very dangerous placenta. So just measure the speed in those lacunae.
Okay, so those are the main ultrasound signs described by the European Working Group, essentially looking at all the vessels, the direction of flow and the velocity of flow. But there are some other aspects that are useful to look at while we're doing the ultrasound. And one of these is the level of venous return that we see in the parametrium, particularly important when discussing with the multidisciplinary team the delivery.
Yeah, because we discuss with the surgeon, so the surgeon asks us many questions, and one of them is there is a lot of veins in the parametrium, and which is the risk to go there. And you can see here that there's a lot of veins in which they are big, and the surgeon prefers to know that before going there. So it's a good information for him. And let's see another example. Okay, this one, this is those are veins into the myometrium, and those one are in the parametrium. And you see this is more than 2 centimeters, and this is nearly 2 centimeters. So the total is about 4 centimeters. It's very, very big. So the surgeon each time asks us about that. What I will find in the abdomen. So tell me. So we can show him this, and it's to describe before the surgery. Okay.
So another, continuing along the same theme of gaining information antenatally to be as well prepared as possible for the delivery, another thing that you can do while performing the ultrasound is to mobilize the uterus and to see exactly what is attached to what. So asking the woman to take deep breaths and seeing whether the uterus is adherent to the anterior abdominal wall, emptying the bladder and seeing whether there's adherence between the uterus and the bladder. And also it's very useful to draw a diagram of what you're seeing, just to give the most amount of information as quickly as possible. So in an emergency situation, a diagram can be a very useful tool to have.
Yeah, and the literature doesn't tell you that. So let's see that. Okay. Okay, we mobilize the uterus, you see, to the abdominal wall, and this is okay. You see the uterus is not adherent to the abdominal wall, and we do the same thing with the bladder. So it's a little bit more difficult to see if it's mobile or not, and we can think that it's okay for this part maybe, and this one is adherent. So the surgeon can see what's going on once again, and maybe he will not go there except if he needs to do an hysterectomy, of course. And so he can know how long is the way to go to the bottom of the bladder. Okay. So we do that just to prepare surgery, and during the meeting, the multidisciplinary meeting, we have to show that to the surgeon just to help him to know what's going on. Okay, here is the diagram that we draw each time. So we draw the baby, the umbilic, and the umbilicus there, and the placenta, and the area which is supposed to be accreta or percreta. So this information is important for the mother, just for her to understand what's going on, but it's also important for the surgeon just to see if the placenta is lower in one part than another one, in which way, in which area the uterus can be more free than the other one. And for this information will also help in case of emergency, if an emergency happening, as to be involved, they can understand very quickly what's going on, and where do they have to go to take care of this mother. So it's important for many people to know exactly what's going on, just with an image, not with a text, for everybody to understand very quickly what's going on. So let's say.
So essentially, the bottom line is these are high-risk pregnancies, which can have a lot of morbidity and mortality for the women. And therefore, it's essential that when we screen pregnancies, that everybody's aware of the ultrasound signs, so that these pregnancies can be picked up as early as possible, and these women can be followed by a multidisciplinary specialist team in a tertiary referral centre in order to reduce the chance of more morbidity for the women. The take-home message is that it's very important to look for these signs, and the major signs that are associated with an abnormally invasive placenta are those of having numerous placental lacunae, so irregular hyperechogenic areas, which may or may not have a halo surrounding them, and important to look at the blood, the flow velocity on colour Doppler as well. Also abnormal placental vascularization. So again, looking at the direction of the vessel flow and the speed, the velocity of the flow within that on colour Doppler. Another sign is the loss of the clear zone, which is the hypoechogenic line that we see between the placenta and the myometrium, and irregular bladder wall. So evidence of invasion of the placenta into the maternal bladder. And these last two signs are particularly seen in the percreta group. Essential to pick this group up because they do have a higher degree of maternal morbidity and mortality.
Yes, once again, the lacunae are more worrying if there's no hyperechoic surrounding. Okay, and at least just one word about MRI, because many people say that MRI is better than ultrasounds for a placenta accreta. We don't think so, and literature doesn't think so also, because the performance is about the same. But we do it each time. Why? Because it is a point of discussion rather than to be used to replace ultrasound. MRI is important to discuss. During the multidisciplinary discussion with the team, a radiologist can give discussion and just to oblige us to say more and more about ultrasound. And it's very interesting in front of surgeons, in front of anesthetists, just to give them the better that we can. Okay, thank you.
Thank you very much.
So, Dr. Grangé, Dr. Noble, thank you very much. This was a very interesting lecture. You did a very good overview of all the ultrasound signs, also color Doppler, about the ultrasound assessment of placenta, accreta, and percreta. Thank you very much. It was really good. Thank you very much. So I would like to remind you that you can place your questions on the chat here on this platform. We will be very happy to submit to our panelists, so they will be there to get a reply.
Okay,
so
let's see the chat.
Yes, there will be on the platform during the webinar for sure, and we will place it with you. We will submit the replies to you. So thank you very much for joining, and we look forward to seeing you all on our Fujifilm Healthcare webinar that we organize for ISUOG. Thank you very much.
Thank you.
Thank you.